Dr. Shukminder Singh Bajwa, who doesn't need any introduction. Sir is the presently our Secretary of IAC National, and there is a long list to go ahead. So just to name a few, he is the ex-editor-in-chief of Northern Supplement of IJA, ex-associate editor-in-chief of IJA, that is to be mentioned, and associated editor of JOACP as well. And he has received a special appreciation from Sir R.D. Ronald Miller in 2003. That's one of the few things which need to be mentioned. So he is going to give a talk on pediatric challenges, anesthesia outside the operating room. It's over to you, sir.
Thank you. Thank you, Chairperson. With your kind permission, shall I proceed further? So, topic is relevant to everyone, whether students, academicians, or the practitioners. We have our own kids, I think, whenever they were young, and giving the kids to somebody to anesthetize our kid, it's always, you know, something, parents, you may be the best anesthesiologist in the world, but you'll panic when you give your kid to somebody else to anesthetize your kid. So that is what Nora is all about, non-operating room anesthesia for pediatric patients. Greetings from my own college and hospital, Patiala, it's the outskirts of Patiala. So straight away coming to the topic, before proceeding further, just like to ask, how many PG students are there? Please raise your hands. Oh, good. So I will be speaking for you people, not to the other people sitting in front. They are very, very experienced people than me. I am speaking at your level only. So it is basically administration of sedation anesthesia to patients undergoing painful or uncomfortable procedure at off-site locations. You tell any kid to silent, to shut down, to sit down. If you can make him a kid sit down, you are the winner. But it's very impossible. So, and we are going to the next step, not just to sit down or calm down, giving anesthesia to such a patient. That is called off-site or Nora. So all these are terminology for that. Why it is becoming more frequent? Because there is increasing interventional procedures with the advancement in the diagnostic procedures, with the diagnosis of the pediatric comorbidities, and increasing complexity of the outside operation theater procedures, growing sensitivity to pain. Nowadays, we don't even, feel everything should be pain-free. Everything should be comfortable level. Everything should be luxurious. That is how our threshold is decreasing day by day. And multiple comorbidities I already mentioned. So, what are the challenges when you give anesthesia to these patients outside the operation room? Remote location, going from if just take an example, you are sleeping in a bedroom every day. Try to shift that bedroom to a drawing room and then try to sleep there. It's a remote location from your comfort sleep. You may not have a very sound sleep the way you have every day. So that is the disadvantage of a remote location. Unfamiliar environment, you are not familiar with all the things around. The workstation is here, the monitor is here, the table is there, the trolley is there, cart is there. So everything is different now. And the physical and ergonomic constraints are always there. Lack of support staff. Many of us are very, tuned to the working with the technicians coming here, sitting here, then the other JRs or you got a senior person also, and even the surgeons and staff also. They are very helping. But suddenly you are shifting to a outside operation room and you will find a staff altogether different. You don't know how to command them. You don't know how to get a work from them. So that is what I call lack of support staff and non-availability of choice of medication equipment according to you. You want to give a particular drug that is not available there. For that, you have to make it available, which is not possible all the time, especially in the government institutions. And anatomical and physiological variations in infants and children. Definitely, they are a very big challenge. You must be reading in your first year books only about the pediatric anesthesia and limited access to patients many times, especially during those radiological procedures. So it is a challenge. All the PGs agree to that. एक बच्चे को एनेस्थीसिया देने के लिए चैलेंज लगता है. isn't it? So Nora, why it is a challenge? Nora is neither as standardized as anesthesia in the operating room, nor it is well studied and reported. How many times we have given a moving child some sedation in the MRI suite or somewhere else, but there is no reporting, proper reporting, no randomized trial, no studies, no analysis proper. So that's why we are getting a less of evidence here. And indications for Nora is basically for deep sedation or GA in non-operating room procedures that involve pain and absolute movement control in a child, which is also very difficult otherwise. And children cannot lie still and be cooperative for a long time. And also for routine procedure outside operation room, if comorbidities are present, that's a challenge. And these are the basically other points which you can consider in these headings, like ongoing apnea and bradycardia episodes, craniofacial anomalies, non-difficult functional anatomic airway problem. So these are things. I will not discuss everything in detail here. So what are the common procedures requiring Nora in children is radio diagnosis, painful procedure in uncooperative patients, especially in emergency room, radiation, oncological procedures, endoscopies, interventional radiological procedures in cardiology or neuroradiology, and lumbar puncture and dental procedures. I think the most common way, if you agree, these are the radiological or dental, which I also encounter almost many times a week. So what are our goals? When we are anesthetizing pediatric patients outside the operation room, the goals are minimum patient safety, which was discussed 2 lectures back during Dr. Madhuri's lecture. The patient safety is the priority. A very young patient, it's a bigger challenge. So minimize the discomfort and ensures anxiolysis and amnesia, avoid emotional trauma, return patient to a safe state for discharge. Now emotional trauma is a 2 components here. One is the pediatric. You can't just slap the pediatric patient, chup ho ja, aisa kar do, hai na? It's not like that. And if you're doing that, you are causing emotional trauma to the mother or the father, who is also standing there. They will say, ye kya doctor hai? Isko doctor kisne banaya? So these things, they come out commonly from those people. So that is what, you should have an art of anesthetizing these patients outside the operation room. So these are the procedure-related risk in Nora. If you're going for the endoscopy suite, there are so many procedures. Either there are procedure-specific concerns or there are environment and equipment-related concerns. I will not go into details. These are very well given in your textbooks as well as available on the net also. Similarly, for the catheterization laboratory, similarly we have other procedures and the procedure-specific concerns and the environment and equipment-related concerns are there. Similarly, in the emergency room or ward or minor OT, especially intravenous line insertion, many times it becomes a challenge for us. Challenge for us in the main operation theater, which is familiar, where we work every day to secure a simple IV line. You get a 26 gauge cannula or you get a lower than that. Sometimes it becomes a challenge. One will say, I will come. Then the next associate say, I will come. Then professor will let me come. And in the last, the person who secures the line is the senior resident. That is because that person is securing it every day. A professor may not have touched that, you know, the dorsum of that kid for a long, long time. But everyone wants to have a glory of regional cannulation. So these things keep on happening every day. Somebody trying on the leg, somebody trying on the arm. So this is a common procedure. And the kids, sometimes you keep on giving the SIVO or any other inhalation anesthetic in the main OT. Now suppose this patient, you have to secure a line in the outside operation room. It becomes double challenging. You are alone there. So what will you do? There is no professor coming to your help, no associate coming to your help. I'm talking about the PG students. Even no senior resident. Arey, apne aap karo. I'm busy in somewhere else. So these things are very important. Other procedures are also there. So I'm just limiting to the cannulation here. Similarly with the nuclear medicine, which we just discussed, and dental sedation. You know, you are giving a dental sedation to a patient. Ideally, what I did in my institution, for all the dental procedures, I have refused to go to the dental college and dental hospital to give anesthesia there. If you want to do the procedure, come to the main OT. So what are the challenges there if you have to give there? Because dental assistants are not trained in the airway management, in helping you in the airway management rather, or in the management of all the resuscitation skills. So that is a very big challenge for us. And how to provide Nora in children sedation, these are guidelines for the non-anesthesiologist. I'm not going to repeat these. And these are the guidelines by the ASA. See, a society in America, sitting there, they have formulated a policy without involving many Indians. The maximum practitioner, the second largest society of the world, where the maximum practice of anesthesia is done. Those people are not involved in the policy formation. I'm telling you, half of the ASA policies will be changed the day the Indians are included in the policy formation. Because the experience the anesthesiologists have in this country is not present anywhere in the world. It's a big truth. But only thing is, it is a representation of our country's things, our guidelines, our recommendations. We have to come out with a solid things, with a recommendation, accumulation of data and putting it into a standard format so as to make our own guidelines. The rich culture, the rich number of patients are there in India. So there are, see, this is one list. If you go through that, what are the MRI compatible equipment required routinely? If you go to this list, it's very interesting. Maybe ECG, electrodes, maybe blood pressure cuffs, respiratory gas analyzer, pulse oximeter, laryngoscope, temperature probe, stellate, endotracheal tube. So it's a big list is there. Now, this big list, if you go through that and you want to give anesthesia outside the operation room, chakkar aa jayega dimag ko. How can I procure this thing? You know one big thing? The biggest challenge is they are costly and the lack of financial backup. I say we are not giving outside operation room anesthesia in a corporate setup where many equipment is available. We are not giving anesthesia in a government setup where also equipments are available. But we are going to give anesthesia in an outside operation room. To get this equipment there, you have to work very hard to get these equipment accumulated there. So this is a big challenge. This is a limitation. And how to give Nora without MRI compatible equipment? Simple jugaad, simple tarika, simple way, putting extensions in the infusion pumps. But how many peripheral hospitals have infusion pumps? How many peripheral radiological centers have infusion pumps? So it's a big challenge. You can't have a long airway tubing because there is no study. If I do the extension of a long airway, a Bain circuit, if I elongate to Bain circuit, then how will you give anesthesia? What is the rebreathing? What is the CO2, expiry of CO2? So there are so many things which are not known, but we are just doing it for the sake of giving anesthesia outside the operation room. So things are not studied well and things need to be studied well. That's why the necessity of such lecture is there, the necessity of such workshops or some simulation procedures are also required for these type of anesthesia procedures. And again, preoperative assessment. I think whenever we are giving anesthesia, we are in the habit of doing some preoperative evaluation. But for outside operation room, always do a proper pre-evaluation because you are going to get incriminated into legal battles, into the social battles, into the clinical battles with yourself, with the people there, with the patient, because ultimate goal is the patient's safety. Sedation techniques. Now, this is a common thing, how we give anesthesia in these patients. Targeted depth of sedation depends upon the procedure performed. Suppose how much tooth to be extracted. Let's take an example of a dental extraction. How much fillings to be done, how much tooth to be taken, how many teeth to be taken out, something like that. And the degree of anticipated pain, whether the painful procedure is there or not. Because in these patients, we are not concerned about the pain. Suppose the patient has to undergo MRI. Any movement of the patient will distort the image. It is a waste of time and energy, waste of the resources if the patient moves during MRI. So it's not the degree of anticipated pain, but the movement also. And duration of procedure, how long the procedure is. How can we make the patient calm and composed during that period? The best part for me, if you ask me, I am more comfortable with a ketamine. Although I really don't know at the age of 1.5 to 2 years, how many hallucinations does a child have? Because if you ask any of the biggest academicians, there are no studies on that thing. hallucinations with the midazolam nullifying it. I don't know the evidence about it. You go to the literature of the world, half of the literature is not well documented for that thing. So, but I prefer ketamine, although secretions are there. I know that you can go for a glycopyrrolate, something if you can secure the line. So that is the best thing for me, but there are other drugs also which we can discuss. So the difficulty in assessment is the communication. Children cannot understand your language at the 2 years or 3 years age. They don't understand the language. Sometimes developmental delay is also there. Early age is, and because of hearing loss also. So many comorbidities are also there. There can be tool of assessing the level of sedation which we cannot discuss in this short lecture. Now coming to the techniques for sedation in Nora, either we use IV gases or IV agents or the gases. Then drugs providing amnesia, analgesia and immobility with minimal effect on respiratory drive are commonly chosen, example ketamine and dexmedetomidine. From the literature what I can find out is that dexmedetomidine is now being increasingly used in the pediatric practice also. Dr. Harsoor sir is sitting there, because when I first published my article, it was the first article published in India about the use of epidural dexmedetomidine. It was an off-label use. We did a study from the ethical committee. It got passed somehow. I don't know how really got passed. But later on, many studies came on the dexmedetomidine, but now it is being increasingly used in the anesthesia practice. So, and the virtual reality of pre and intra-procedural distraction, like use of music videos. Nowadays, we have got so much gadgets, so many, like mobile phone. Every parent is proud of showing, beta ye dekh, see this, how this cartoon is doing. Everything we show the mobile to them, and the kid is very, suddenly, at that developmental age, how a child perceives that moving image. But they become very calm. Somehow it is working. The technology is working in our favor. But I don't know how much it is going to affect later on. And after 7 years, that parents say, "Arey, mobile chhodte hi nahi hai bacche yaar." So who are the persons who have given that habit? So it is something like both ways. And there are other role plays and feed and swaddle strategy. I don't carry on these things. These are not much of importance. So sedation for non-painful procedure, we'd already discussed CT, echo, EEG, genital examination, routine physical examination type. And the non-pharmacological intervention in distractions, simulations, videos, audios, just like these are things we do every day in our practice. The more you learn, I think we were having discussion about the learning curve of anesthesiologists. After passing out immediately, a PG student may not be able to do these non-pharmacological interventions. But I think after 7 or 8 years of your practice, you know how to calm these patients. When you have your own kids, you become more a learned anesthesiologist. That's the way life goes actually. So, and pharmacological, we have IV route like midazolam, ketamine, and again dexmedetomidine and propofol. These can be used for sedation for minimally painful short procedure like peripheral IV line placement. These are common procedures. Urethral catheterization, small laceration repair, NG tube placement. These are the procedures being done outside commonly. So you can go for the inhaled nitrous oxide, midazolam oral, sublingual or IV. Dexmedetomidine IV only. Don't give dexmedetomidine IM or by any other route. It is to be given only by IV. And other procedure like fracture reduction, bone marrow aspiration, burn dressing, if you go with the moderately, severely painful procedures. I think this is also we have to do sometimes. But I think better to mobilize these patients to operation theatre rather than attempting to give anesthesia or those off-sites. And pharmacological intervention like IV ketamine, ketofol, propofol, fentanyl and these drugs, including idometrid also. The sedative, now we coming to little for the PG students, what they want to write in examination, doses have to be mentioned, not just the drug's name. So IV ketamine 2 mg per kg bolus or IM 6 to 8 mg per kg provides sedation for 20-25 minutes. But I am telling you one thing, don't give ketamine in the pre-op room when the patient is in the lap of the mother. The kid may not be knowing the needle, its impact, but the mother will know. You inject the injection into the kid and the mother will have a post-traumatic injection for a long time. And she will keep on explaining to every relative of this, he has to undergo big injection, the dad, and the long stories will formation. So Even in the pre-op room, sir, I will take 3-4 minutes. Because we have a time, na? Thank you, sir. So these are the things we have to take care of while anesthetizing these patients. So other drugs are, I have already mentioned, the midazolam in the dose of 0.5 milligram per kg oral or 0.2 to 0.3 milligram per kg intranasal. Have you used intranasal or not? The PGs, PG students, everyone, आगे वाले सबने यूज किया हुआ है, पीछे वाले PG student पीछे बैठते हैं हमेशा, the backbenchers, कभी यूज नहीं किया, okay. So you can use 0.05 to 0.1 milligram per kg IV and Dexmed 1 to 3 microgram per kg IV bolus over 10 minutes followed by 0.05 to 0.1 microgram per kg per hour. You should be very specific with the dose. These are the established doses now. Or propofol alone or in combination with ketamine and fentanyl for GI endoscopy. So intraop, you can go for the monitoring SpO2, heart rate, NIBP, ECG. We just had a visit to the ScanRay factory here. I was having these, looking at these monitors also. But outside the operation room, our monitors are not that much standardized. They are not good, but at least you should have pulse oximetry. The minimum monitoring standards, I think, were found by ISA. Dr. Harsoor was there. He was the one of the author in the formation of the monitoring, minimum monitoring guidelines for the pediatric or any patients. So I think we should be going by that. And if airway obstruction occurs, maneuvers to relieve obstruction, I think you go by your own procedures. What have you learned in your operation theaters? Same procedure to be repeated here. LMA is always better to carry a pediatric LMA if you are going to do any procedure outside the, it's a very, very much recommended rather than endotracheal tube. Sometimes you may not be able to intubate, but with the LMA you can feel very secure psychologically also. Then post-procedure care should be done in designated areas and equipment for emergency station should always be ready. SpO2, NIBP monitored. NIBP I don't think so we monitor that much in pediatric patients, but the pulse volume is very important. Your clinical sense should also make you a good anesthesiologist. And discharge criteria according to Eldred score or other scores, whichever you are comfortable with. And GA with endotracheal intubation, when the indications are basically MRI where the patient keeps on moving in spite of sedations, and the critically ill child or TE intervention cardiology procedures or neurointervention neurological procedures. So these are the anesthesia concerns in the different age group. I am not going to in detail, but the adolescents, they have only one thing, fear and anxiety of the procedure. And factor affecting anesthesia plans we have already discussed. GA for pediatric, Nora we have already discussed. I think same thing, I can't repeat again. That's like difficult airway equipment, it cannot be explained again and again. So maintenance of cerebral perfusion pressure and intracerebral pressure control in neuroradiological intervention procedure, these are important when you are going for an intervention in radiology. And intra-procedure invasive monitoring, ABG analysis, sometime in intervention cardiology procedures. But I think if the patients, I disagree with this line, although I've taken it from one of the books where chapters, ABG analysis is, if is existing in that particular setup, that means they must be having a very good setup of OTs and the workstations. And maintain intra-procedure normothermia. So these are the intra-procedure problems which you can encounter one by one: desaturation, hypotension, arrhythmias, hemodynamic instability, hemorrhage, thromboembolisms, and contrast-related risk. You have to manage these complications basically outside the operation room. So these are the challenges in children taken for CT, like when patient of head injury or unstable respiratory status, unexplained change in mental status, potentially unstable airway, need for breath holding during 3D airway procedures, and child movement during contrast injection. So these are the comorbidities which pose challenges in CT. And mortality and morbidity in these patients occur due to pulmonary aspiration. That's the biggest cause for morbidity and mortality. You have to prevent aspiration at any cost. And air-related complications, transport-associated events, allergic reaction to the drugs, and hemodynamic deterioration. So CPR in MRI room is very, very difficult. Whatever you read, whatever you study, whatever been taught, but a CPR in MRI room is very, very difficult. So you have to be very good in resuscitation skills if you are going to give anesthesia in outside the operation room. So areas of research, there are a lot of areas of research. So many editors Sitting here, at least they will also guide you how to go about it, because there is absence of published data on frequency, timing and demographics of pediatric non-operative room location anesthesia, tracking, auditing and analysis of all clinically important complications associated with Nora, difficult airway scenarios, anesthesia techniques in children taken for abdominal CT or MRI, and use of high flow nasal cannula for oxygenation during sedation. These are potential areas for your thesis also. When your junior comes, you can give these topics to them. But in operation theatre or in main hospital also, you have areas where you give a non-operating room anesthesia. These are strategies which we have already discussed. So take home messages. It is challenging, no doubt about that. Pediatric Nora requires thorough preparations, vigilance, monitoring to provide safe anesthesia care, and improvement in quality of anesthesia services and outcomes in Nora can be achieved through development and following of relevant guidelines and collaboration between anesthesiology, pediatrician and administration. I don't think so. This is a bullshit. I can't believe this. I tried my administrations many times that provide this thing. Nobody agrees. Even if you go to your institution, I challenge, the administration will fall into the anesthesiologist's hand in providing everything. It is here we have to work. Here comes the role of seniors here, the policy makers here, to make the administrations work according to the safety profile of the patients given or outlined by the anesthesiologist. This is a big truth. We are falling here. We give every type of lectures, every type of things, but in the policy formulations, this is here we are falling apart. We are not into the central stream. Even in the CBME also, how many anesthesiologists are being considered, because majority of the topics are being covered by the pharmacology department, by the other departments. We are not given the priorities in that. It happened in my institution also. It must be happening in the colleges of other states also. So this is area where we have to work upon to provide safety. That means the policy making has to be by the senior peoples here. Dr. Gangadhar, are you listening? Na? So you have to make policy about it. So presence of well-trained personnel and the presence of an anesthesiologist can reduce mortality and morbidity in pediatric Nora. You are the best person. Today's PG will be the best pediatric anesthesiologist and clinician in coming days when the procedure is done outside the operation room. Thank you.